Now, hello and welcome everybody. It's my pleasure to welcome you to this, the third online implementation workshop in relation to the action plan for stroke in Europe. And today we are dealing with the stroke service tracker. You all received a link about a week ago together with a completion guide, and many of you we can see have already been into it to have a look around it. We're very, very pleased to see this interest. Today, the program is that first Professor Norwing will share his experiences in how and why data can improve quality of stroke care. And then I'll give a practical approach to how the stroke service tracker works. Afterwards, we will go into the groups to discuss how to deal with the stroke service tracker, and also so that we from the implementation committee can have a lot of good feedback from you on how we can improve things and make things work a little bit better. And then we will finally meet again, share your feedback, and that is basically the program for today. So now I will give the word to Professor Bo Norwing.
So wonderful. Thank you. Can I just have a quality check first? That can you hear me? Can you see my slides? Wonderful. Wonderful opportunity. Thank you so very much for giving me the opportunity to speak to you on why and how do data improve the quality of stroke care. So we have had this recommendation with us to have evaluation of stroke outcome and quality assessment with us already from the beginning, actually, from the first Helsinki Board Declaration in 1995. This was one of the first documents to emphasize that evaluation of stroke outcome and quality assessment should be an integral part of stroke services. It was also in the second Helsinki Board Declaration from 2006. Again, this was a separate domain, evaluation of stroke outcome and quality assessment. And is also one essential part, as you know, of the stroke action plan for Europe. One of the reasons that the SAP-E was organized was that the intentions of the previous declarations were not fulfilled. The targets were not met, and this includes evaluation of stroke outcome and quality assessment. So this is a very, very important part of it. So I will start with this slide, go back to a slide here shown on an earlier webinar in this series, the chain of arguments for advocacy of stroke. First, to demonstrate the size of the problem. Second, refer to an evidence-based source document and action plan. This is a SAP-E here. Third, demonstrate gaps and inequalities. Fourth, show that substantial improvements can be made. Fifth, to demonstrate that actions are extremely cost-effective for the society. And finally, to measure progress, surveillance, and quality of care. So do we have data? Yes, we have some data. We have this important pan-European survey, which you're all familiar with, showing that there are large inequalities in the stroke care among the European countries. This is a very important starting point, but we have nothing like the stroke tracker so far. So what do the data do actually? I will give you some examples from the Swedish Stroke Registry. This was the first national stroke registry in the world. It started in the mid-1990s. We have had a stroke registry ongoing and active in Sweden now for more than 25 years. So I will show you this graph, which I think is interesting. This shows the inequalities, the variability on Swedish hospitals in some of the key domains here in stroke quality. And what you see with green dots are hospitals that meets the high target of performance. Yellow is the meets a moderate target, and these are the signs below target. So look, for instance, here on antiplatelet therapy at discharge, and you see that almost all hospitals do this. It's easy, you see that is no quality problem, it's uniform across Sweden. Now, when we look at reperfusion, these are data from 2021, you see that there is quite a large variety among the Swedish hospitals. Some are green, Many are yellow. Quite high proportion do not come up to the target level. If we look at the door to needle time, to have that below 30 minutes, the proportion, you see that there is a huge inequality between the hospitals. It's a widespread inequality which is not acceptable. And recording of NIA stroke scale, you see that there is some hospitals who perform well, some do it moderately, the majority do it. So what has the development of this been over the years? I will give you 3 examples. The first one in anticoagulant therapy after ischemic stroke in atrial fibrillation. And what you can see from 2015 and onwards is, yes, there are more green dots. There has been an improvement, and you can see that the variability among the Swedish hospitals has decreased with time. So we can see that, yes, there has been some progress in this variable. If we look at the proportion of ischemic stroke treated with reperfusion, you can see that, yes, it is some improvement, but it's not dramatic. It's very slow. It demonstrates that it takes time to have an improvement. And final example is this proportion of thrombolyzed patients within 30 minutes. And you can see that even if we know how important this is, even if we know the data, we have our own data, and this is completely in our own hands to manage, you see that the progress is indeed very slow. So the lesson is that only to have the data, it doesn't do the job. This was one of the slogans that was used by Margaret Chan, the WHO Director General, for several years. What gets measured gets done. And many of us thought of that, well, is this really true? What did she really mean? But she emphasized this again and again. So the background here to this slogan is that the original language is actually what gets measured, get managed, is not get done. And what the person, the originator, emphasized was that you focus on regular measurement and reporting of key indicators. And that means that you get the focus on exactly these items. But it's a misconception that data alone do the job. They don't. Absolutely not. So here we go back to these slides. And here you see the importance to having the data. Demonstrates the size of the problem. We need data collection. Demonstrate gaps and inequality. We need the data. To measure progress, surveillance, or quality of care, we need the data. So data is a very, very important part. And data on stroke services needs to be integrated into the full SAP-E implementation plan. And you need that on the regional level, national level, local quality wheel also. Data needs to be valid. This will be discussed. Data alone do not do the implementation job. You need to have this integrated into the full implementation plan. Importantly, without data, the SAP-E would be completely lost. We will not have the argument, where are we, what needs to improve, how far as we come. We need the data from every country, and we need solid and robust data. Without the data, we know nothing. We cannot even argue for the implementation plan. So my last slide, measuring quality of services is essential in the stroke action plan. Stroke service tracker is a core function in the SAP-E. Stroke service tracker includes the key indicators, well chosen, carefully chosen. Improvements do not come automatically. It's no quick fix. It requires hard and sustainable efforts. What is recommended in the SAP-E is perfectly aligned to some upcoming important WHO declaration that will be released later this year. There is one global action plan on NCDs. There is one action plan on epilepsy and neurological disorders, of which more than 40% is stroke, emphasis on surveillance and monitoring. The SAP-E implementation, in my view, is a role model for all diseases. This is probably the most effective way to improve services overall in any disease. And also in this field, stroke can take the lead and show that we can do it and be a role model for other diseases. So thank you for this. Good luck with the work today and with the webinar. Back to you, Hanne. Thank you.
Thank you very, very much, Bo, for this great talk. I will continue directly to my own talk. So this is really about the practical part of this, the practical part of how to use the stroke service tracker. You have received your country's unique access about a week ago, and I have seen that many of you have already entered and had a look at it. But first, what I really want to do is to thank those who have spent a lot of time on helping us, especially Yannick Akov from Estonia and Georgia Trigoulis from Greece. They have beta tested the platform. We are extremely grateful for it because you have taken out, we're sure, not only a lot, but also the worst bugs from the system. So let's have a look at the platform. When you enter the link, which you had sent by an email about a week ago, you will get to a screen looking like this. And this is where you enter the code, which is specific for your country, and click on the submit your return code. Then you will go to where you can enter the data from your country. And this is set up this way because obviously only Sweden should be able to enter data from Sweden, etc. Because so this is why we have to have this double access. Then you enter your own country, and I have pre-filled some data from Denmark. It is not really precise, this data, it's just something I filled in to have some examples to look at. But when you go in, you will see the country and the year. When you go into your links, you will see the year 2020, because this is the year for which we're collecting data at the moment. Next, what we'll do is that you will have a look. Sorry. The next where you will go to is that you will have to enter data on the data sources. As Bo also mentioned, the quality of data is extremely important, and we're handling this the way that you start off by mentioning what kind of data sources you will be using and defining these and documenting these. So if you say you're using a national register, you have the option of either putting in a link to this national registry or uploading a file with documentation on this. And this is basically to support the trustworthiness of the SAP-E, the SST, the stroke service tracker, but also to make it possible to enter data which is perhaps not the best data in a comparison to other sources of data, but is the best data available in a country on a certain topic. So you can go from national registry with mandatory reporting and cost checking with national health surveillance data and down to an estimate. The important thing is that everybody will know where does this data come from. This is how we ensure the quality of the data. The next part of it is the basic variables, and these are basic variables like the number of patients and how many beds in the hospitals and things like that. All data to be entered is aggregate data. This means it's completely anonymized, meaning that there's no GDPR issues in this. So when you are to enter data, now I give the example of ischemic stroke. First, you select what is the data source. And then after in entering the data source, then you enter the number of patients. So this could be an estimate, or this could be data taken from a registry. And if you do not have any data or any estimate to provide, then you click data not available, which is possible, and then the hard stop will be deactivated and you can continue without entering data. This may also be relevant if you find out that there's a certain number you do not have ready when entering data, then you can just click data not available, continue, and then come back to this variable. The next you get to is facilities for stroke care and programs. This is fitted with the earlier mapping so that we can look at the development over years. And first you enter if data is available, and then only if data is available, then everything opens up, and then you can fill in first the data sources and then the numbers. And then you also tell us whether, sorry, my mouse is almost alive, except when I want to go back. Sorry. So then you fill in both as to certificate, both as to quality programs and to number of units, etc. And you also have the option always of filling in to make some extra notes if you feel like that. And please notice that that we also ask questions for facilities outside of hospitals in order to ensure that quality can be followed for the entire chain of stroke care, even though we certainly do know that quality programs in the communities are very scarce. But that is also a message that there's no data. I have then you get to the section on key performance indicators. A lot, some of it is where you can say like work is ongoing. This is the first key performance indicator, which is whether you have a national stroke plan. And in Denmark, the work is ongoing. And then you can simply click this and it is recorded without documentation. If I had entered that we did have a national stroke plan, then I would have been asked to document it by putting in a link to the document or uploading the document. A lot of the key performance indicators are automatically calculated based on the data you've entered previously. Things like how many of the stroke units do have a quality program. Then in this case, it would be 100% because all the stroke units are audited and reporting to a quality registry. And in that way, it is already calculated. Another example is the rate of reperfusion therapy that will be calculated based on the previously entered numbers of patients with ischemic stroke and patients receiving reperfusion therapy. So when you have finished uploading data, then you are basically ready for the national audit and benchmarking. You can basically audit your data as soon as you've uploaded it in the stroke service tracker. The steering committee will ensure that this uploaded documentation is verified for obvious reasons. But you can already continue to do your auditing and benchmarking before having the feedback on the verification of the documents. The auditing is basically meant to be a reflection on how things are at the moment, how they can be improved, and what benchmarks you want to set. You should set then benchmarks that are reasonable, benchmarks that you should be able to meet if you are working hard on it. But you are also allowed to prioritize between benchmarks because we all know that everything cannot be done at the same time. So this is meant to be a working tool. You're supposed to enter data on the data sources, and that will be more relevant for some KPIs than others. And then you are to comment on the assets and the challenges. And of course, in the beginning, you're also to enter who will be in the national auditing board as we've discussed previously. Then you comment on the results, both the data sources, the quality, how reliable are data, what can be improved, assets and challenges. We also would like you to make a short note even when the KPI is met, because sometimes, even if it's met, there may be something which could be relevant to indicate. It could be that it is met for the country, but there are areas where this is altogether not at the same level as other areas. Then at the bottom of the page, you will, Then at the bottom of the page, you will have a list of the previous benchmarks from the previous years, so that you can easily see.
Está boa.
Pardon?
Olha, queria te perguntar, que há uns tempos o hospital colocou anúncio, aviso para...
I think somebody I think somebody is on the mic, so I'll just continue. You will also see the actual rates, if it's rates like the reperfusion therapy, and you will be able to comment on the sources, comment on the assessments, and again, you will see where has the level been for the previous years. So at the end, please never forget when you exit the system that you should have your return code. You should copy it and you should save it, because this is the way you can return into the data of your own country. Because when you need to copy this return code, when you get back in, you need to put it in here again. And then I must have slipped one slide, and I want to go back to show you this one, because there's some important information in this, and sorry about having somehow passed this, because what I really want to tell you is the timing of the upload. There will be data from 2020, which will be uploaded. I think I have a problem with my mouse. I'm really sorry. The timing of the upload, data from 2020 will be uploaded you should upload it by mid-February this year. And then you will be asked to do one more upload this year, which will be by June. And then that will be just once yearly afterwards until the end of this project. And when can you then expect to see results? You can actually see the results on KPIs and key variables. You can see them yourself right after you've uploaded them. So you can see it as soon as they're in, you can see it from your own countries. As for the entire project, the KPIs and key variables for all countries will be posted on the website about 6 weeks after the deadline for upload. But of course, this is depending on us getting the data, because we cannot upload it if we haven't received it. So we really hope for your collaboration in this, because it will be so far more interesting for all of us if we quickly can go out and see and compare ourselves to others. And what will we do with the data? Basically, what we want to do is to give the data back to you for you to use to improve stroke care in your countries. So we will give it back to you to allow for comparisons between the years and between countries. We also plan to publish core data after peer review, and that is basically to ensure that there is trust in data, that people do not think this is just something on some or another homepage. We want to do it that way to make the data stronger and more useful for advocacy. Because data, as Bo also explained and described, is a very, very strong tool for quality improvement, because this can be used to identify areas in need of improvement. And data will strongly support advocacy for stroke. And your next steps, those will be, one access has been provided to the national coordinator who is responsible for the upload. You can upload this yourself, you can delegate it, you can be a group who helps each other. If you want, you can have a list of the variables. Megan will be happy to send that to you. But the national coordinators, someone is responsible, but you can delegate however you want. The upload is country specific. This is not personal, but please keep it safe. Activity on the platform is logged. This means that we can see when somebody enters the countries, and for those of us who are administrating the system, our personal activity can be followed. And please notice that a written instruction has been circulated. If you meet a problem, look at this, or perhaps read through it and use it when entering it. And if there's problems anyway, then please contact us. Josephine Grundry, her email address has already been circulated for you, is happy to assist you. If it's more than a simple question, then we can plan a video conference where you can share your screen and we can better help you. And then please form your auditing committee as soon as possible. Involve people from all regions of your country. Involve the stroke support organizations. This is extremely important. And ensure that the group is representative, because the impact of your benchmarking will basically depend on this. Thank you very much for your attention. Now we're continuing to the next part of the program, which is that we will enter into to the group rooms, where we will start the discussion. Welcome back, everybody. Are everybody back from the breakout sessions?
Yes, apparently.
Yes, right. Because then we will continue with the feedback from the 4 groups. And first, I would like to ask West to come forward and give us a short resume of your discussions and impressions.
West, is that Francesca and I?
I believe so. So you should feedback, Aline.
Okay. Do you want me to share my screen, or shall I just talk through it quickly?
Oh, you can share your screen if it's helpful, please.
Okay, I'll be very quick, and Francesca, please jump in. So we had Catalonia, Portugal, Spain, and Belgium in our room. We also had Francesca, who was moderating, and we had Christina as an observer. Just moving on to the kind of the 3 questions about uploading. Many of the countries are still deciding who's going to do this. I think people were quite honest. They are still working this out. They are working out where they're going to get the data from as well. We talked about stroke registries. We talked about accessing data from the Department of Health. We talked about accessing data from the local stroke support organisations as well. So there is still to decide who's going to do it, and still to decide where the data is actually coming from. Was there anything else, Francesca, on just the where and how we're going to get the data from? Or shall I move on?
No, please move on.
Okay. The concerns, we got to concerns. There's quite a lot of concerns that were being discussed, and again, can just group them together. That it's the people are actually are concerned about how they're going to access the data. So if they're going to national institutions, departments of health, etc., for national information, this is going to take some time and might not necessarily be on time for the deadlines that we have set. They are concerned, we've been concerned about which year this data is going to represent, and that the data that is collected might be from 2019, it might not be 2020, certainly won't be 2021. We have concerns about who's going to do it and who's going to have the time to do that as well. Anything else, Francesca? Okay, and then just finally about the benefits. We did spend a lot of time talking about the who and the how and the concerns. But I think overall, we know that the picture is going to be, there will be a lack of data, there will be gaps, and there'll be, but what we're hoping is that over the years, as we continue doing this, this will convince our politicians and our clinicians that we do need to do this and we do need to do better. We hope that this, by presenting the results back, we should be able to encourage, stimulate clinical research and better care, and also more interest in the Stroke Action Plan for Europe itself. Have I missed anything, group? Is everybody happy with that?
Yep.
There we are. Thank you.
Thank you very much, West and Arlene. There was one comment about how to enter patient data that I think was from Portugal. Patient data, individual patient data is not needed. It's only aggregate completely anonymized data like number of patients with strokes and things like that. So there's no GDPR issues with this. It has been designed to avoid GDPR issues. And thank you very much for this. I think you are very much right that this is also about pointing out where we still need data in order to say something qualified. Then I would kindly ask East to come forward and present the feedback from your discussions.
Thank you very much, Hanne. To be honest, we had more questions than answers. Actually, let me repeat and wrap up the main questions and issues we discussed. So first, how to organize data upload, taking into account that each country in the region receives data in different time. Like the Czech Republic mentioned September. The Slovakia mentioned also late summer, early spring for final data and so on. So if the deadline for data entering is spring, for instance, then most countries will not have data by then. So we should consider how it should be organized. Then the next question is, what sources of data are we going to use? We will probably need the full list of data needed to be prepared and circulated, because if you don't know the full list of data that you will need, it's rather complicated to manage the system, the platform. You don't know what you need on the next page until you finish this page, so it's difficult to prepare the data in advance. Then we discussed whether or not we can clarify what should be uploaded, if anything, because some countries have databases that are quite complicated, difficult to deal with, and some countries have a kind of mix with elements of personal patients' data, which we definitely don't want to be entered in the registry. Then we discussed that we need a comment on how to use the code, because some colleagues, they face some difficulties when entering the system. Some attempts went smoothly, but some had to look the code from the beginning. It was kind of a bit of confusion about the using the code. Then one major potential issue could be using local definitions versus universal or generally accepted definitions, for instance, for a stroke unit. In Hungary, they call a stroke unit the place in the hospital where thrombolysis can be performed. So no other additional requirements for a stroke unit. In other countries, different places. In my country, in Ukraine, there is no generally accepted or official definition of stroke unit yet. And some hospitals say they have stroke units. And should we believe them, just take for granted, or try to somehow verify? And if try to verify against what criteria? In Kazakhstan, there is a difficult situation with the unrest and military problems, as you all know, and they do not have official data for 2020 due to both this unrest and the COVID pandemic. Robert, Professor Mikulik raised an issue: how are we going to deal with bias? Because a lot of data are going to be biased that countries enter into the system. How are we going to have any kind of verification? And colleagues from Poland, they mentioned that they have a national registry, National Health Fund, with the database of all their numbers of patients and procedures, but this registry doesn't contain outcomes yet. About more than half of the stroke units in the country, they provide data to rescue, but not all of them. And in Romania, there is no national registry. There are 43 centers providing data, some data, but so there is no full amount of data. And this is also true for Ukraine. We have only official statistics by the Ministry of Health, but we don't have the national registry or any other sources of reliable data in the country.
Thank you, Yuri, for so precisely pointing out, I think, a large number of the problems that are part of a project like this, because this is an attempt to track stroke care quality in Europe. And we are, of course, all of us in the steering committee of SAP-E aware that we will not be able to find first-class data for all items for all countries. Unfortunately, we know that. We're trying to come around this as good as we can. And to go by your questions, which are all of them extremely relevant. First you are say data is received at different times, and will be able, different countries will be able to upload data at different times of the year. I would suggest that that we discuss that on an individual country basis, because basically the system could run with countries uploading at different times of the year. So this is something which can be fixed. Then you ask about data sources, and you are completely right, because some data sources are high quality and some are more or less estimates, you know, like this, putting the finger in the air. The way we try to work with this is that for all for all information, it has to be clicked what kind of data it is based on. So that is why we start off the tracker with the coordinators defining what kind of data sources they have. And they only do this once, because otherwise they would have to do it a million times, but you can define many kinds of data. And then later on, you enter what kind of data source is this information based on. So you might enter that the total number of strokes in a country is based on an estimate, or that it's based on a registry, or that it's based on a number of regional registries. But not the entire country. So it's possible to indicate the quality of data by the source of the data, and that's the way we've done it, because I mean, we can't improve everything in all Europe from one day to another, even though we would love to. Then about the data upload, we will ensure that a list is circulated of the variables. Megan will circulate a list for all of you, because probably we should have done that earlier, because right now it is obvious for me that we should have done it earlier, but it was not obvious for me a week ago, you know. It is only about aggregate data, no individual patient data. And if there's a variable or more variables where you have no data, then you simply click no data. That's always an option. There are no hard stops. You can always click no data and then continue. And you can also come back if you want, if there's something you're missing on your list, and then come back. Then there's about the code. We have talked to several countries, or the representatives of the countries who had problems with this code. We have made a guide with now with screenshots on it, how to do it, which has also been circulated. But please, sometimes these things, even though they seem simple when you know what to do, can be completely impossible, at least for me. So please, if you have looked at it and you just can't make it work, don't fight for an hour or something like that. Contact us and we will help, because that's what this is, what we're here for, because we want to assist you as much as possible in getting this done without too much pain. Then there's the question about local definitions versus general definitions of stroke unit care and units. Yes, that is certainly a real problem too. And the way we discussed this and decided to solve it in the steering committee of SAP-E was that we have a number of definitions of stroke units that can be ticked. So after defining data sources, then you go to defining what you call a stroke unit. And we have a number of definitions, and of course there will be more definitions out there, but we have a rather broad list of definitions. At least this was the sum of what the steering committee could come up with, and those who helped us with the beta testing, they did not comment on that actually. And then you click what fits best. And if you say, like, you have a local definition, a country definition of a stroke unit, then you're supposed to either upload a document or a link to this definition. And of course, we do know that, of course, in Hungary, people do not speak English to each other or Danish or whatever language. Of course, they speak Hungarian. So we will have to deal with having documentation in a number of different languages, but we will ensure that this is checked to a reasonable extent, that this is actually a stroke unit definition which is uploaded. So that is how we will handle that. Then the last issue is missing data, and yes, missing data is missing data. A lot of countries do not have outcome data, or do not have outcome data linked to data on reperfusion, at least only outcome data for the first few days. But missing data is also important in what is our overall aim, which is to improve stroke care. By saying that, what I mean is that if we need some data to be able to better identify problems, to work better with it, then that there's no data is also a signal that can be used for advocacy to improve stroke care. And there will be missing data for any country, I think, in the stroke service tracker, because this is certainly an ambitious document, but we have tried to make it feasible for all. I think I responded to at least the majority of your questions and comments, but this does not mean that the discussion has ended.
Thank you very much, Hannah. Yeah.
And sorry, Francesca, you're right. I'm forgetting time. We still have. Let's go let's go to north first, and then end up with south. And I'm sorry, we only have 7 minutes left because I lost myself in this.
Thank you. We had a good discussion and we discussed the same problems here. And the problem was that in most countries, they have good data from acute stroke, but not so good from TIAs, and ischemic stroke, but not so good for TIAs and hemorrhagic strokes. And in many countries, there is a need for use different sources. And but those countries who have national stroke registries get all data from their registries and from mainly from the Nordic countries. So in some countries, rescue database is also used, but unfortunately the coverage is only 20–30%. And this can be a source, but not all data can be achieved from there. And there was a question raised by some countries that there is a time lag for reporting, and some countries receive reports for example, for 2020 this year. And can this be extended so reporting for 2021 is too early for in June? This is a problem. And of course, the same problem that we do not have data for life after stroke and outcome data, and in many countries do not have follow-ups. So, but as you mentioned already, that this can be left, put no data on these gaps. And of course, one problem is that we do not have data on stroke in community, but unfortunately, this is very difficult task and challenging, and probably it's more is better to use the hospital data. So that is basically all we discussed.
Thank you very much, Jannica. You were very, very clear, and this is very useful. And then I would like to give the word to South to end up the feedback from the regions.
Hello, I'm here. Just a moment. Okay, so we had 10 participants from 7 countries, and we discussed mostly the issues regarding entering and accuracy of data in the registry in this SAP-E tracker. And the main problem is maybe that all participant countries doesn't have national registry, which could be easier to perform this, and many of these data will be related to estimation, and that is the main issue. And we are all interested to participate, and time is running, so I agree. We agree. We all discussed in partial all some things from other, which are already said. So Hanne, please, thank you.
And thank you very much. Yes, we have come to the wrapping up. First I want to say I am so grateful for so many people participating. I have noticed that so many countries were represented, that I could see from the faces that both people from the SSO and people from the scientific societies were well represented. For me personally, this is a great pleasure to see. For SAP-E, this is really important. You have provided us with extremely useful feedback. We will immediately start working on this. because there are some issues where we can certainly improve the plan based on your feedback. As for now, and as for the first update of 2020 data, I will kindly ask you to continue with this as good as you can, because this is not an easy ride for any countries. No country will be able to find all data. No country will be able to upload all data, but we need to start from somewhere. So I will kindly ask you to proceed with this. And when you have problems, anything you think we can assist, then please drop an email to Megan or Josephine as the first, or to me, and we will do the best we can to assist you. And then we will get back to you and discuss further how to proceed with the data and tell you the ongoing progress of what we're doing. So thank you very much for joining us today.